Well, I'm Elizabeth Darby. Oh, got it. Okay, we're being recorded. Okay, I'm Elizabeth Darby. I'm the Director of Organizational Development and Vendor Management for Indiana Medicaid. This is Sarah. Well, I'm Sarah Foster. My pronouns are she, her, hers, and I am the Vendor Manager for Non-Emergency Medical Transportation. So Sarah oversees our fee-for-service program, and then I oversee all of our administrative services. If you've worked with Medicaid at all, you know we are a very small agency. We have less than 100 staff for all of the Medicaid services in the state. And so I oversee all of our administrative contracts and transportation. I've been with Medicaid since 2019, but I've been with the state a total of 11 years and worked in the private sector as well. And I actually worked previously as a consultant with IU Health. So if my name or face seems familiar, I used to work with the community engagement office out of Methodist on the Strong Schools program and some of the day of caring, things like that. So what I'm going to do is I want to share a quick presentation with you that kind of level sets on transportation. I know that one of the questions was really specific to SET, and I want to make sure that people understand the complexity of our transportation services because SET is only one of multiple brokers that are used. And the broker that the member is assigned to is dependent on their care plan. So I just kind of want to level set on that, give you some statistics that are literally hot off the presses. Yesterday, we received year-to-date statistics for 2019, 2020, and 2021. And the number, and it's literally millions of medical visits that we've been able to support over the last 3 years. So non-emergency medical transportation has changed a lot since 2018. And the biggest area is volume. We have more than, I want to say, the last stat I heard was 8 times as many trips on average, and managed care trips are increasing daily and regularly. But we have really been able to expand the service that we can offer to people who are on Medicaid, both in the direct transportation, but also in alternatives that might better meet their needs. So we'll go through those. I'm going to show you some statistics and tell you about some new or special changes that we made either due to COVID or throughout the public health emergency, and then I'll open it up for questions.
Okay, and Elizabeth, some but not all of us are really integrated with transportation systems and issues. So if you could also, as you go through, try to explain any acronyms and things. I know when you say SET, you mean Southeast Trans, but sharing those things for people who may not know would be very helpful.
Absolutely, absolutely. So again, this is an overview of our non-emergency medical transportation. We do work with emergency medical transportation a little bit as well. We are the subject matter experts here, but as you may know, emergency medical services are managed by the Department of Homeland Security. So we partner very closely with them, but our focus is on non-emergency medical transportation. So just to level set to make sure everybody's on the same page, cover some of those acronyms. We are the Office of Medicaid Policy and Planning. We are a policy office, so we do not do direct member services. All of our member enrollment and direct member services is supported either by vendors that we contract with or by our partners at the Division of Family Resources who do our eligibility determination. Our vision is to build programs and processes that enable Hoosiers to live fully engaged communities and reach their greatest emotional, mental, and physical well-being. So this is the perfect group to talk to because what we want to do is empower your community to help support our members. Our mission is to support Hoosiers' greatest well-being with efficient and effective programs, remarkable collaborations, measurable impact on individuals and community, and an energized staff that is fully engaged in our mission. A couple other things just to level set. Medicaid is a national program. It is the 3rd largest mandatory spending program in the country, right behind Social Security and Medicare. All other mandatory programs, and that includes the food stamp programs, all mandatory education services, everything else is only 11% of the federal budget, whereas Medicaid is about 9%. Those numbers will shift up a little bit because of new spending, because it's from federal fiscal year 2018. All non-discretionary funding, which does include defense spending, obviously is the biggest portion of the federal budget, but from those mandatory side, we're right there. What that translates to is that Medicaid is actually 35% of the state budget, and it's 90% of the Family and Social Services budget. So everything that FSSA is doing, almost everything, ties back to Medicaid in some way. And the other big program that we have, although obviously dollar-wise it's not as big, is the SNAP program, which is the food assistance. Let's see. So our numbers to date, and actually this data is not as of 5/31, it's as of August 31, but we have 1.9 million members. As I mentioned, our staff is only just shy of 100 people, so that is why we have to go with vendors and brokered services. Also because those services have opportunities to do things that the state either legally or administratively cannot do. Those 1.9 million members, about 770,000 of them are children. That number has stayed very, very stable. And then about 1.1, 1.2 million are adults. Our adult population has grown because we have not removed anyone due to the public health emergency. So right now, if you're on Medicaid, you're staying on Medicaid all the way through the public health emergency, and we're not redetermining any eligibility. Of those adult population, about 125,000 are seniors, 214,000 are people with disabilities, and 232,000 people are duly eligible for Medicare. And I mention that because the minute we bring in dual eligibility with Medicare, we add a layer of complication to the whole thing because we do not manage Medicare. Medicare is managed by the Indiana Department of Insurance due to Social Security rules. But we do partner with them. It just makes things a little bit different. Long story short on why that is because Medicare by federal law is the first payer and Medicaid is the second payer. So if someone is eligible for both programs, either due to disability status or their age, they go to Medicare first. And then they come to us for services and we pick up any remaining services that are needed. The way that we operate at OMPP is that we have two different kind of delivery services. We have a managed care program, which serves almost all of our members. As I mentioned, we're just over 1.9 million, and about 1.9 million of those members are on managed care. The other pathway that we have is the fee-for-service traditional Medicaid program. And the big difference between that is whether or not there is an insurance company that is servicing the member. On managed care, they're assigned to one of our 5 partners at a managed care entity, and they manage every service that that member gets. With our traditional Medicaid, those bills are coming directly to us. They don't have that intermediary, which also though means that they don't always have that same support. But those bills are coming directly to Medicaid and we're paying for those services. When we talk about Southeast Trans and the transportation, as you'll see moving forward, they only service that column on the right, that fee-for-service population. The managed care entities all have transportation services, but they broker those separately through their own contracts. And that's why we have multiple brokers. And it also depends what plan they're on of how much transportation services they get and the types that are available to them. Again, I will continue to go through that as we move through and get you those contacts information, but I just kind of want to explain that. I think this has been one area where we've needed to do a better job explaining the difference between the two programs and the volume of people. So on to non-emergency medical transportation. It is exactly what it sounds like, but we do get a lot of questions. So who it is for is all Medicaid recipients get some level of medical transportation. There are no limits. There used to be a limit of 20 trips a year that has been taken away and will not be coming back because of public health emergency. There's very few reasons why you'd need prior authorization. We've removed that as well to remove barriers to services. So members simply just have to let their broker know they need a trip, and it's pretty much covered as long as it's for a medical appointment. In addition to members, we do allow escorts and attendants as needed. So particularly with your population, if it's going to help a member understand or maybe get to an office in a big building, I know we've had issues I've been dropped off at Methodist Hospital and not knowing where to go, quite honestly, up here in Indy. So we do allow escorts to ride with members. That could be a spouse or an adult child. And in the case of children who are being transported, they are required to have an adult escort. We do allow for attendant care also, and I will explain that a little bit more in a few minutes. The escort does not need to be approved, but we do need to know who they are. So it just is a note on there, and we will actually do screening questions with the member or with the person scheduling to recommend that they need an escort. So if they maybe have any kind of dementia being one thing, or any kind of capacity issues where they may not be able to find the appointment themselves, or may have issues getting in and out of the vehicle, then we would request an escort. And there's no charge for that. All of NEMT is free from charges. So if you ever hear someone being charged, please reach out and let us know, because they should never, ever be charged, and they should not tip. This is a more recent thing that I've heard, that members are tipping. All of our members are very low income, and we don't want that. We do pay the drivers fairly, and they are given, full wages, so they don't need to tip drivers. So where will we go? We do cover the entire state of Indiana. And we also cover Indiana healthcare providers. So that's our registered providers for Medicaid in select neighboring areas. In Kentucky, we cover Louisville and Owensboro. In Ohio, we cover Cincinnati, Hamilton, Harrison, and Oxford. In Illinois, we cover Danville and Watseka. And I do not know why we cover Watseka. It's kind of in the middle of nowhere, but for whatever reason, we have a provider there. It could be that there's a VA clinic in that area. Sometimes that's what we cover. And then also in Michigan, we cover Sturgis. You'll note we do not cover transportation to Chicago. Chicago is not deemed an Indiana necessity county. We do have to request that by CMS in order to be able to cover an area outside of the state. And because Indiana has all levels of hospital and care available in the state, we are not able to include Chicago as a tiered provider. It doesn't mean sometimes they couldn't go. There'd have to be prior authorization and demonstration to the federal government that the service was not available in the state of Indiana in order for us to cover a trip to Chicago. That often does come up. However, we do cover Cincinnati Children's Hospital and Louisville Children's Hospital because for some families that is a much more reasonable drive than it would be to go all the way to Riley or Peyton Manning Children's Hospital. So what we cover with non-emergency transportation is medical appointments. This is actually the most frequent question we get. So we cover on-demand acute care doctors, dentists, and eye appointments. We cover recurring or subscription appointments for dialysis, chemo, radiation, wound care, anything that's one of those standing order appointments. We do pickups and drop-offs for inpatient and outpatient surgery. You can be transported for lab work, and we also will do pharmacy pickups. And that can either be if you're leaving a doctor's appointment and the doctor calls in a prescription and you need to pick it up on your way home, or if it's a separate appointment, maybe you had telehealth, but you need to go to the pharmacy to get a prescription. With our pharmacy, particularly in those cases where it's connected to telehealth, we cannot do delivery though. The member has to be picked up and taken to the pharmacy to pick up the prescription themselves. The member does have to be present unless they're a minor child. So we can't pick up just an escort or just a family member and take them. We have to have the member with them. In the event of scheduling conflicts, we do prioritize what we call subscription trips, which are those standing orders, due to the intensity of the need and the impact on members if they were to say miss dialysis or chemo. The ways we cover transportation, we have ambulatory services, wheelchair services, stretcher service. Some members can use public transportation if that's available in their community. And we also have in Indiana code, gas reimbursement requirements that are for either an able-bodied member to drive themselves or to be driven by a family member or a friend. They do have to still schedule that. They can't just go and submit a bill, but they do need to contact their broker. And then they get reimbursed at a mileage rate. I will say the mileage rate in Indiana code is not the best. It actually is the same rate that state employees are paid. which currently is, I believe, 44 cents a mile. However, all of our brokers have decided to add to that, and most of them pay different rates. So members should always ask what they're going to get paid, but it is a per mile rate, roughly around 50 cents, which is pretty standard with the federal rates as well. If the trip is not scheduled, though, they cannot get reimbursed either for mileage or if they took a taxi and did it. So the scheduling piece is really the most important, and that's hard, quite honestly, with our populations. But that is a real important piece that they do need to call in advance and schedule. All of our brokers are able to handle last-minute trips. It can be difficult because, like everyone, we are experiencing shortages in employees, particularly with drivers. So the more advance notice they can give, the better, but we can accommodate urgent trips that are not rated as an emergency. And of course, if it is a true emergency, they are asked to call 911 instead and be transported by ambulance. So how they receive their NEMT services is again based on which path they're on. So our fee-for-service members just call Southeast Trans or SET directly. You might also hear them referred to as SETI. Their corporate office adds the I, and the state office does not. Either way, all the same company. Again, that's for about 17% of our members. If they're on managed care, they would call the number on their insurance cards, and I'll show you where you can find that in just a second. That's about 83% of our members. And then if they fall into that group of about 250-ish members that are duly eligible, they need to start with Medicare. And my understanding with Medicare is that they just book their trip themselves with the provider. And so that is where it sometimes gets it. And Medicare does have a limit on the number of trips they can have in a year. At the point where Medicare stops, if they're duly eligible, we would pick up and continue the transportation. All of our brokers do know how to work with Medicare as well and can always help members with more complex needs or if they're confused. Really, the brokers are the transportation experts, so that's why we refer to or defer to them. So I just want to show you quickly what the cards look like. I am missing one because we have a newer provider and I don't have a clip of their card. But if they're on managed care, and this is how you know if they are, they have a branded card and it says who their insurance provider is. It has all their numbers. So they're either going to have CareSource, MHS, Anthem, or MDWise. The third option is United Healthcare. And again, it's very similar. It's just going to be branded with that United Healthcare. And then there's going to be the phone numbers on the back that they call to schedule their trip. In most cases, you're still just calling the general number. It's all embedded within the managed care plans. Again, with fee-for-service, it is you call Southeast Trans directly because we don't do any of the scheduling here. So now I want to just cover some NEMT statistics. And as I said, we were just pulling these for the governor's office. So you're the first group to actually see some of this information. I bet that even his office hasn't seen it. So consider yourselves very in the inner circle on this. NEMT by care program, I apologize, this is a little small, but I can send you a PDF of the slides later. So the Healthy Indiana plan is about 30% of our Medicaid membership, but they don't use quite as much of that as the total transportation. Healthy Indiana plan is our plan for 19 to 64-year-old adults, and this is the plan where people are most likely to be working. So it makes sense that they use a little less transportation services through us. However, it is important if you're working with this population that they know they can get reimbursed for mileage. My worry with the Healthy Indiana plan is that people are driving themselves on a limited income or buying bus passes themselves when they can get them from their managed care plan. The next one is Hoosier Care Connect, and you'll see that is our smallest program. They're only about 6.3% of the Medicaid population, but they use about 16.5% of the transportation services. That actually makes sense to us because that is our plan for those who are aged, blind, or disabled. And so the volume of appointments that they have is much greater. If you looked at our care services as well, you would see that they go to the doctor simply more than other parties. Hoosier Healthwise, which is our program predominantly for kids. All of our kids are on Hoosier Healthwise. And then some pregnant moms is about 42%. They do use transportation, again, at a much, much smaller rate. Again, my concern here is that parents are transporting kiddos to doctor's appointments and not realizing that the benefit is available to them. And you can see that kind of went up. That's the 2019 and 2020. We're seeing some better. Managed care has had a priority to increase and improve outreach on transportation services because their volumes were not where we expected them to be. So you'll see as we go through the slides that their services are improving and growing. You see the icon they want us to click on? Oh. Oh, is that better? Hopefully, I'm gonna move.
Yeah, but if you click on that icon right next to it, just to the left of that minus sign, it will enlarge it to the whole screen.
There we go. Is that better?
Oh, way better.
Okay. And so these are our numbers now. If we look at 2021, fee for service, as I said, has gone down because our other programs have grown substantially. So fee for service right now is about 20% or 20%, 17% of our total Medicaid population. And it's still sitting at about 50% of our transportation services. Again, because these members don't have some of the other supports, and this membership is our lowest income group, they have the least access to other resources, but they also, this is a group that is very well aware of their rights and their benefits under transportation. So I think they utilize it quite a bit more. And if we could get some of those other numbers up, it would probably balance much more directly. So here's our new data through September 30th, and I just got this yesterday. This is medical visits supported by program type. And I have a little post-it somewhere that I just think I got rid of. But you will see that we are supporting literally millions and millions of appointments. In 2019, we supported over 29 million visits. And that is just stunning to me. In 2020, we supported almost 37 million visits. And then so far in 2021 through September 30, we supported 31,000 visits. And that to me is, I think, the most amazing statistic. I don't know that many people realize the volume of medical visits that we support with our transportation services. Southeast Trans. I want to dig into that because I know there were some questions. Again, it is just one of the brokers, but because we manage that contract directly, we have a lot more information about their services. When the brokers work through the MCEs, the way it works is the managed care entity manages that contract. They manage their performance, they do all of that, they actually do the vendor contracting. And so we are slightly removed from their services. We still monitor it, we still look for similarities and make sure that all the requirements are met, but it is done at a higher level with the managed care entities than Southeast Trans, where we have a direct contract with them. So these are the numbers from Southeast Trans last contract year. Their contract is funny. As far as the cycle goes, it runs from June until May of every year. I'm not sure why that is. It's just something I inherited. But you can see the average calls for trip requests per day is in the high 700s to upper 800s. And that stayed pretty consistent even during the public health emergency. It did drop a little from the previous year, but overall it stayed pretty consistent throughout the public health emergency. The average calls handled per day is just over 12,000. The average number of members served per month, and this is unique members, is about 10,000. And then in claims, which are those which are going to correspond to an actual trip, they do about 136,000 claims a month. You know, and there's some claims data there just because that is something that the Non-Emergency Transportation Commission really pays attention to. Some things that might be of more interest to you: the average one-way trip legs per month is 46,000. Now, this did drop significantly during the public health emergency. We had reached a level where we were more on the range of 60,000 per month. But again, with doctor's appointments being canceled, elective surgeries being canceled, things like that, it did go down quite a bit. 57% of the trips are subscription or standing orders. That stays pretty steady in that high 50s to low 60%, largely because of coverage for dialysis. And so dialysis is our #1 reason why we're transporting people. About 43% were acute care. Again, especially in Q1 of that contract year, right when the public health emergency was starting, that number dropped quite a bit. As you all probably know, a lot of people have missed out on their preventative care and wellness visits, and that directly impacts transportation. SET had a fulfilled trip rate of 86%. That is a little lower than our goal. Our goal is a minimum of 90 with a primary target goal of 98%. We have really high expectations for transportation, so we do hold all our vendors to a very high standard on fulfilling trips. However, one of the biggest issues with trip fulfillment is the member no-shows. These are members who, for whatever reason, maybe they choose not to go to the doctor, maybe they're feeling better, but they forget to cancel their appointment or their ride, or they simply do not show up for their trip. If you took those groups out, the fulfillment rate would be about 95%. Let's see, I've got a question here. What is the response for getting our approved? We will talk about that because driver no-shows are a different issue actually, but I will go into that in just a second. For member no-shows, what we do is outreach. One of the things that is different about fee-for-service from managed care is in managed care, the providers can give them a cell phone. And with fee-for-service, we have a large population of members who do not have cell phones. And that kind of impacts where we can find them if they're at a different door than the driver, but the driver has no way to get a hold of them. That does complicate things. So we're working to figure out how we can get more members' cell phones and access to immediate communication. We do also have a designation for high-risk members. These are members who have missed a trip and also have a serious medical condition. Largely, these are members who have those standing orders but have missed trips. We are particularly concerned when people miss dialysis on Mondays, particularly after holiday weekends, chemo or other treatments that could cause extenuating or worsening of their health care or health conditions. SET, as of May of 2021, had about 13,000 active drivers and 1,300 active drivers and about that many active vehicles. It is possible for drivers to share a vehicle. For example, if a husband and wife own a company, they might both drive the same van on different shifts. We are working actively with SET to increase both the number of drivers and active vehicles available, particularly in some high priority areas, which I will show you in just a few minutes. My slide does not want to advance. There we go. So here is our provider areas of need. The green counties are areas where we do not have enough vehicles for the population and the trip demand. So we are focused heavily on getting vehicles to these counties. However, vehicles are not limited to just serving one county. So when we add a vehicle to Marion County, it likely will serve the entire metro area. Same as Vanderburgh County and Clark County as well. They really add to that whole community. You will see we do have a large demand for more vehicles in the northern part of the state. So if you are aware of any organizations that are interested in becoming drivers, we can get you that contact information at the end. The outreach plan for this is kind of multifold. One of the things that SET is doing to help find more providers is to ensure that facilities know that they can enroll. It's kind of a win-win for everyone. If a nursing facility is able to transport even some of their drivers, it helps them with their health outcome standards, which is one of them is to ensure that members get to their doctor's appointments. So the facility is actually partially responsible for that. And it also gives them income. So we pay for those trips. And if the trip was unassigned and let's say the nursing home Hoover would decided, well, I got to take Mrs. Smith to the doctor either way. If they're not a provider in the SET network, they can't get paid for it. But if they enroll, they can take Mrs. Smith and 2 other people to the doctor and get paid for those trips. So that's one strategy. We also continue to work with EMS. Of course, right now our EMS system is pretty tapped out with COVID response, and also with some of the emergencies that have happened. We have multiple ambulance companies right now that are diverting fleet to just do hospital to hospital transfers for COVID positive patients or for facilities that are over capacity due to COVID. And we also, during the most recent hurricane, we had several providers send fleet down to the coast and to both Louisiana and to New York to help with those emergency recoveries. Transportation development, though, is an ongoing discussion. It is a challenge across the country right now. So we are looking at it both at the county level with SET, the state level with SET, but also nationally with all of our partners and all of our brokers to find new ways to engage providers and get more people. On the question of driver no-shows, there is actually standards within the vendor contracts with their broker. And there is an intervention strategy if they either send a trip back late, which is a real reason why trips don't happen, is because we get less than 48 hours notice that the driver cannot take the trip, or if they just don't show up. There is a complex intervention strategy that varies a little by each vendor, but I can tell you at SET, it involves first meeting face-to-face with SET, developing strategies, figuring out exactly why. There's a big difference if a driver canceled a trip because they were COVID positive versus they got tickets to Kings Island and just didn't want to work that day. So we do need to find out why they're not showing up if there's an issue. I can give you one example. We had a facility in Evansville where they were reporting a lot of missed trips due to driver no-shows. And my team and I talked with the facility, and I had Googled it, and just to get a little bit of frame of reference, I'm not as familiar with Evansville, so I wanted to, feel a little bit more comfortable with the type of facility I was looking at. And when I Googled it, I noticed that where it said the facility was on the map and the directions that Google gave me did not end at the same point. And so what happened is that's what was happening to drivers. The facility was on a large hospital complex. The address was delivering the driver to a different, completely different street, about a third of a mile away from the actual assisted living facility doors. And so again, without cell phones and the ability to contact people, there was just a complete disconnect. So those are the kinds of issues we work through with people. And SET will create plans if there's a facility that's particularly having a problem, or if there's a member that's having a specific issue getting their transportation. Again, and I will get to the SET questions kind of at the end. I want to kind of frame out what we're doing and some of it because it'll answer some of the questions that you have, but I'll come back to that question as well. So some program updates that we have, NEMT, both through SET and through our other brokers, has provided and will continue to provide transportation for any member to any location that is providing a COVID vaccine. As the age group changes and more children are able to get vaccines, we will cover their transportation as well because we want to make sure everyone can get access to that. Attendant care. We did change the policy on attendant care with our partners at the Division of Aging, and this is particularly important, I think, for your group. Previously, we had stopped allowing attendant care due to duplication of funding. CMS told us we were not able to use both funding streams for it. We have worked with them to create an alternate path. So attendant care for transportation is allowable for all members who are on the aged and disabled waiver, the A&D waiver, or on the traumatic brain injury waiver. It allows members with complex needs to have a person attend with them, and this is like a paid person. So this isn't I mean, it could be a spouse if that's who's doing their attendant care, but this is that paid attendant service through the waiver. So it allows that person to be there and be paid for their time. And it makes sure that it's someone that the member knows, particularly with people who might have a cognitive disability or traumatic brain injury. There's a level of comfort in making sure that the person is someone who really understands. It also mitigates health risks to the members by not exposing them to people outside of their own household or caregiver circle. And then it provides companionship again to the medical appointment and helps ensure that the care needs are understood. So that's a more recent change that we've made. Through the public health emergency, we have made a lot of different adjustments that we are working to make permanent throughout our plans. Some of those things, again, also are eliminating trip limits because we know for people with standing orders, we'll go past 20 trips really quickly with dialysis. So we're taking away some of those barriers. Another program update we have is in a partnership with Southeast Trans or SET. Anyone who calls Indiana 211, regardless of their Medicaid eligibility, can get a Lyft ride to substance use disorder treatment. What we found was that when people call and are ready to get treatment, delaying it to try and figure out how to get them there can really break down them accessing that care. So we wanted people who called and asked about substance use treatment to be offered a free ride within so many hours to get them to a facility where they could start their treatment. This is really a brand new partnership, and it's done with Indiana 211, the Division of Mental Health and Addiction, and OMPP, and we're really excited to get more data on this. Because we know with the opioid crisis and other addiction issues and the complications of the public health emergency, many more people are facing addiction and needing support for that service. So I do want to go through the contact info and questions, and then I'll go back to your questions and open it up for you to ask more. This, and again, I will send you this to Dana as a PDF so you have it. This is the Southeast Trans information. Their quality assurance number is the most probably important for you guys to have to call. The Where's My Ride line is that day of number. If someone is waiting for a trip and they're not there, they have to call this number for two reasons. A, they can tell them whether it's been dispatched or if there's a problem and get an alternate in place. And also because this is one of the main ways that we track how especially return trips are being handled. The trips that get picked up from the house, those are scheduled on a time frame, but the return trip home is always done based on when the member is done with their appointment and having to call. So having this Where's My Ride number is very, very important. You can also see I put in the Southeast Trans member portal number or websites. You can go there. Members can schedule online. Facilities can also schedule online. And this website has more Indiana specific information. Below that, I did include the administrative contact numbers for the managed care plans. As you can see, Anthem uses a company called WellTrans. MDWise uses Motive Care. And then CareSource, MHS, and United Healthcare all use the same broker, and it's called LCP. And those are the administrative ones. Again, for members to schedule, they should call the number on their card. Lastly, I put in our contact information. Again, Sarah is the Southeast Trans NEMT vendor manager. So specific concerns with SET services, once they have been routed to SET for initial things, if you're still not satisfied, then you can reach out to Sarah. You're always welcome to copy her on any emails or communications Southeast Trans. But in reality, we will route concerns to them for the first intervention. I also included my information. You again are welcome to copy me on that. I will say I'm a little bit slower with email just due to volume, but you can also reach me at the phone number below. And that is all I have. I want to go back to the questions you had about sorry, I'm trying to stop sharing and do something at the same time. So I want to go back to the questions you have about quality. So all of our broker contracts have quality measures in them. And with SET, there is the NEMT commission. So it's a bipartisan commission that has community agencies, member representatives, legislative representatives who manage the SET contract. We do also, specific to the question about driver no-shows, there is a standard, and SET cannot have more than 5% of their missed trips be because of no-shows. If they do fall below that, they have to do corrective action, network development, and we do manage their kind of regional network development throughout the year. The real reality is we face a lot of challenges, right now, because we have lost drivers. It is a tough market, as all of you probably know. Labor markets right now are very, very tough. And so SET is working with some kind of non-traditional or alternate partners, like community centers and church groups, to get more people on to do transportation. That said, becoming a registered transportation provider is a complex process. It can take about somewhere between 50 and 120 days to even get registered. Because you have to become a certified motor carrier with the state of Indiana. And again, you probably already guessed, that's handled by a different agency, of course, because motor carriers, of course, they do not go through the Department of Transportation. They are handled by the Department of Revenue at the state, because it is a tax source, because of vehicle taxes and things like that. But that motor carrier certification process is 45 days on average. Because there's a 30-day waiting period and some other things. The other issue for drivers is that you have to have $1.5 million in liability coverage per vehicle. That's for the safety of our members, and it does include a specific rider for sexual assault and molestation, which is an added cost. But our members are a very vulnerable population. We transport children. We transport people with developmental delays. We transport people who are ill and just simply vulnerable because of that. And so we want to make sure that all the vendors meet the highest standard and have that coverage in place. Also, the reason that coverage is so high is because, quite simply, automobile accidents do happen. And automobile accident expenses can be very high, obviously, and very serious. And so we just have to make sure that the insurance standard can really protect people. So that does make it difficult. It's not to make an excuse for drivers who don't show up, but we have to report that if SET doesn't necessarily know, or if a member doesn't cancel, it just adds to it. And so we're really teasing out, and Sarah works with SET really on a daily basis to dig into why that is. But I will say the driver shortage has really affected all of the brokers.
I think Michael's question in the chat too also asked about the types of evaluations that are done. Is it based solely on completed rides, or is there some way that consumer satisfaction is measured, or what does that look like?
Absolutely. Yeah, so SET does, and again, this is specific to that contract because that's the one we manage directly. SET does have to do consumer satisfaction surveys. Quite honestly, their consumer satisfaction surveys are amazing. They get very high rankings from the people who do it. And where I have a concern, quite honestly, because I see your face, what I need people to do in the field is not drop out. And so what my concern is that people get frustrated, whether it's a member or it's a facility. If they just simply stop using SET because they're frustrated, it actually sways it to make it look like the services are doing better than they are. If people just don't schedule with SET, and they need those trips, well, then those missed trip rates go way down and it doesn't look like there's a problem. We are a data-driven system. The commission is a data-driven system. And so a lot of it has to come from trip volume. The unfortunate reality of things like Medicaid is, and you guys are all in healthcare, a lot of things come back to that paper claim or electronic claim, but that claim. And so if the claim is never there, if it never got started, then I don't know that it got missed. And so that's one of the things I really need to encourage people as you're working with the community, is to really encourage people, If you opt out of any system that's not working, if you opt out, it sways the numbers the other way, and it doesn't show when there's a real problem. The other thing I would say is that there is a combination of factors that go in. So there's qualitative things, there's safety measures. They have, I want to say 30-ish measures that their performance is based on. And so they have quality measures about inspections and all of those things. They also have provider statistics. Like I said, there's a driver statistic, and that's all framed in their contract. And those are all things that the NEMT Commission sees and reviews. In addition, the way we pay providers is they get a % of their contract withheld, their payment. And if they don't earn it back, they don't get it. So we do withhold from all of our vendor contracts, performance withholds, and they either meet that standard, which again, as I said, for fulfilled trips is a minimum of 90%. They didn't get that money back. And that's just a reality that they know. They have very clear standards in their contract, and if they don't meet them, they don't get it. And in the case of NEMT, it's not only do they have to meet them, the commission also has to approve their earning of any of the withholds. And so that is a double check. And you'll see if you go to the NEMT Commission meeting, they meet twice a year. And so in their summer meeting, they just reviewed the performance withholds and the standards, and you can see all that data on that website. But that is a thing. The other piece to know is that it's not just a free for all with the money. So we do pay them on a capitation rate schedule, which means we give them a per member rate, which is roughly $7. It's not an exact formula to that, but that's the composite rate. It's roughly $7 for every member eligible for their service. Just specific to SET, not, believe me, we pay Anthem a lot more than $7, but so they get that per month. At the end of the cycle, we will go back and look at how much they actually paid in claims. And we'll compare how much they paid in claims to how much they earned. And they have to meet a standard of at least 85% paying for direct transportation of members, or they have to pay us back until they get to that. So they cannot just keep endless amounts of profit. That is true for our managed care entities. Again, the numbers are very different, but the percentages are all, the minimum standard that we have is 85%. In some programs, it's even higher because we know those members have higher care needs. So they don't just get to pocket whatever money they get and pay whatever they want. We see their rates, and the rates are, there's a base rate and mileage. So we are kind of monitoring all of that. It gets really deep in the weeds very quickly with Medicaid funding and how capitation rates work. But I can tell you that we do have a lot of people. The other thing with those rates is we do not determine them. They're determined by a third-party actuary, medical actuary service at Milliman Health. And Milliman determines those rates based on the actual care needs from previous years. And they look at members by demographics and trips and things like that to determine the rate that we pay for all of those services. So that does kind of set it. I know there's some concern that we just give them this lump of money and they can do whatever they want with it. And it's not quite that way. It does, of course, because again, big system, it takes several years for us to kind of go back, but we have recouped funds from them and we will continue to do that if they're not meeting our threshold.
Thank you, Elizabeth. I feel like we could have you back 10 times and still have like 1,000 questions. So I appreciate you providing your information.
So what I would encourage is that you have Southeast Trans come to talk more about theirs, because how they do their services and the things that they can do and the added value that they bring to the table and some of the things they can do is very important. And as much as I try to understand, I do manage about 14 different vendors. So I don't want to speak on Southeast Trans behalf, but I would recommend that. And they need, I think, to know more about different areas. And you might have partnerships in Bloomington that they're not aware of. I know that is an area where we do need more people, more so right next to you in Brown County, which might not surprise any of you, but Brown County is really hard to serve for transportation. And so looking at ways that they can partner with you, and I would encourage that, and Sarah can help you set up an appointment with them.
All right. Well, thank you so much. And I will send out a link to this recording. So if you want to watch it again, I know it was like a ton of information. So
Is-
you need to refer back to any of that, and I will send it to the other group members too. I just saw another email pop up that said, oh my gosh, I didn't realize what time it was. Sorry, I didn't make
That's
so
okay.
I know
okay.
there are others waiting on that. And I think maybe it would be helpful for us, as we have heard this information now, if we can come up with ways that our clients, neighbors, friends, coworkers, whatever, can advocate on their own behalf if there are issues that are happening now that we have a little more information about that.
The other thing I will add, Dana, is we are doing the long-term care reform right now, LTSS reform. That's going to change transportation. And it's going to change a lot of things, but I'm always the big advocate for don't forget about transportation, because as more people want to stay in their homes, we have to have more transportation to get them to appointments and things like that. So if you have feedback on that, there is an LTSS reform email box that goes to the secretary's office. Dr. Dan Rosiniak is the new secretary.
Could you send me a link to that?
Yep, and we will definitely get that to you. So as you're thinking of anything as far as long-term care needs go, you can send in that feedback. They're taking questions, they're taking suggestions, and there is, again, a bipartisan group looking at long-term care reform and LTSS. And so this is a good place to kind of bring that in and to include that of if more people are going to stay at home, how are we going to service them? How are we going to make sure that they can get to their doctors? How are we going to, I mean, telehealth's great, but if you don't have internet, it's not so great, right? It's not even an option. And so all of those questions you can also give to that group, because that is where you're going to see a lot of the shift emerge from at Medicaid. My transportation team and my staff really deal with what we do right now, day-to-day operations, but there is that larger reform and evolution going on. And so feel free to give feedback to them.
Okay, well, I appreciate that. So if you send me that link and your slides, I'll make sure to get that to the team. I also have some information, I can't remember if I sent to this group, so I'll attach it as well, about how family members can apply for and be qualified to be a Medicaid transportation provider in appropriate circumstances. So my APS team meeting, we talked about that a lot, and I think it would be helpful and relevant perhaps to this group too. So I will share all of that with you, and I think we can dig into that and look at that a little more at our next meeting.
Okay.
Any other things that anybody wants to share before we part or ask? Okay, make sure you're signed up for our Dementia Friendly Indiana Conference on the 12th, in person and virtual in Canby, Indiana. We're pulling together all the last minute stuff for that. So Liz, I think you are the only one in this group who is working as a vendor. Amanda and Andrea should be reaching out to you in the next couple of days to give you more details about what to expect, how to plan for that.
Well, yeah, I was going to ask you, I was planning on bringing like a table and a board to kind of just at least be the drawing point. So they'll reach out to me and I can let them know what I'm bringing.
Yeah, and we should have tables and everything, so you don't have to worry about bringing your own table unless you just needed some kind of special something or other. But any equipment, things that you need, plan on that, and they will talk to you a little bit about the flow and how we're working with COVID stuff still to make it interactive.
Great. All right. Thank you.
All right. Well, thank you all for being here. I'm